Hello, fellow Raise Lab team. My name is Aneta Vega, and today I will be presenting on ADHD, symptomology / presentation and diagnosis in youth versus adults. Attention Deficit Hyperactivity Disorder, or ADHD. What exactly is ADHD? ADHD is a neurodevelopmental disorder. It is commonly referred to as an umbrella term. This is because the symptoms of ADHD are grouped or clustered into three main categories or subtypes. Those subtypes are the inattentive type, the hyperactive impulsive type, or the combination type. So how exactly is ADHD defined? The American Psychiatric Association defines ADHD as a neurodevelopmental disorder characterized by impairing levels of inattention, disorganization, and hyperactivity/impulsivity. It is important to note that these traits must reach a level of impairment in an individual before it's considered part of the characteristics of a disorder. The prevalence of ADHD in the US is listed here. You can see that children have the highest prevalence at 11%, and adults have the lowest at 4.4%. Now that we have a basic understanding of what ADHD is, let's talk about two important terms that you will hear throughout this presentation. The first term is symptomology. And although the literal definition of this word refers to the study of symptoms, in this presentation, we will use this to refer to how an individual will perceive and characterize behaviors either within themselves or in others. Clinical presentation, on the other hand, will refer to how clinicians interpret symptoms and the criteria that they will attribute to them. For example, an individual may say that one of their symptoms is not being able to focus on what their teacher is saying during long lectures. This behavior, in and of itself, is not a clinical presentation. However, a clinician will, and often does, attribute this behavior to the second symptom criteria under inattention, which is often has trouble holding attention on tasks or play activities. So now that we have defined these terms, let us move on to looking at ADHD criteria as established by the American Psychiatric Association and how it is listed in the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders. As mentioned before, there are three main subtypes of ADHD. Here we see a list of only two subtypes because the third subtype, which is the combination subtype, consists of a combination of symptoms from these two subtypes, inattention and hyperactive/impulsive. Feel free to pause to read. Note that each subtype is made up of 8 clinical presentations that are characteristic of the subtype. If you take the time to read these symptoms, you will notice that symptoms under inattention are in relation to mental processes of attention, whereas symptoms under the hyperactive impulsive are in relation to mental processes of movement. Here we can see a breakdown of symptom counts used to determine if clinical presentations meet the criteria for ADHD. Let's look at inattention to understand what this means. In order to meet criteria for having the inattentive type of ADHD, an individual who is a child or up to the age of 16 must show that they have 6 or more of the inattentive clinical presentations of ADHD. For individuals who are 17 years old and older, they must have 5 or more of the presentations. In addition to the clinical presentations being present in an individual, clinicians must assess the patient's history to understand if these presentations were present before the age of 12, and if they are present in 2 or more settings. These settings can include settings like home, school, and work. Another important factor is that the symptoms reported by individuals interferes with their daily lives to a level of impairment. It is entirely possible for an individual to have ADHD and not experience impairments from their symptoms. This could be for a variety of reasons, including but not limited to individuals' coping mechanisms or living in low-demand environments. And finally, clinicians must be sure that the symptoms reported are not the result of effects from other disorders. Now that we have a better understanding of ADHD presentation and diagnostic criteria, let's talk about how the signs of ADHD look different in youth versus adults, and what the diagnostic process looks like for youth versus adults. We will do that by first focusing on clinical presentations in children. When a child is referred for an ADHD evaluation, it is important to understand how their behaviors affect them and those around them. The field of psychology has established a long list of measures intended to assess the behavior of children. From questionnaires and surveys to scales on behavioral factors, these assessments are used in a variety of ways and generally are chosen by clinicians to tailor the assessment needs of the child. This can mean that not every child being screened for ADHD will be given all of the same assessments. However, there are some very common assessments given to children, including the Conners, the ADHD rating scale, and the KSADS, to name a few. For children, inattentive symptoms can manifest in many ways. Usually they are behaviors of concern that negatively affect education, parent-child relationships, and social relationships. One study on inattention in children identified 2 behaviors that were significantly associated with inattention: easily distracted and does not listen. In addition, they found that inattention was a predominant subtype for girls. In the hyperactive impulsive subtype, it was found that it shows up most in younger children between the ages of 3 to 6, and that the predominant behavior was difficulty in sustaining attention. However, these behaviors are not normally reported by the child, but rather by an informant who reports their perceptions of concerning behaviors observed in the child. These informants are usually parents, caregivers, close relatives, teachers, and medical physicians. As you will see, informant reporting is a critical factor in identifying, assessing, diagnosing, and accessing an ADHD diagnosis and treatment. How others view the signs of ADHD will vary, and if viewers are incorrectly interpreting what they see, this could have negative consequences for the child. In a study conducted in the US, it was revealed that the study sample stigmatizes children with mental health problems and are more willing to coerce children into treatment. Furthermore, children are often seen as dangerous due to misconceptions of mental illness. It is important to identify and assess signs of ADHD in children as early as possible. Early intervention for ADHD has many implications on quality of life outcomes for adults. Late diagnosed people experience more problems in daily life with their executive functions than those without ADHD. Executive functions, which include things like the ability to plan and begin tasks, are an important aspect of living and participating in life to a level expected of most adults. Studies on predictive signs of ADHD in infancy show that ADHD signs can be identified when considered together with an infant's self-regulation behaviors in order to predict ADHD. For this reason, it is important to understand how presentation changes on a developmental level throughout the lifespan. Figure 1 above illustrates the usual progression of ADHD from early childhood through to adulthood. Figure 2 is a visual representation of the network of ADHD symptoms and how they associate with each other in the three main domains of development: childhood, adolescence, and adulthood. If we take a closer look at Figure 2, we can see that the red dots represent inattentive behaviors, yellow dots represent hyperactive behaviors, and purple dots represent impulsive behaviors. Take note that beginning in childhood, which is the chart on the left, there are mostly inattentive and impulsive behaviors that are clustered and mostly separate from each other, with prominent behaviors being the hyperactive behaviors. In the next chart, which is the adolescent network, we see an introduction of impulsive behaviors that come within about the same association to the other subtypes, as well as stronger association in general of all behaviors, which is indicated by the darker green lines. In the adulthood chart, we see a general switch over of subtypes, where the predominant behaviors are more of the inattentive behaviors. Both these figures illustrate a trend in the progression of ADHD subtypes that goes from hyperactive impulsive behaviors toward inattentive behaviors as individuals develop from childhood through to adulthood. Now that we can see how development affects presentation, let's look at how presentation in adolescence differs from childhood presentation. Although criteria for ADHD does not change for each stage of development, the American Psychiatric Association has taken care to add language to the DSM criteria that includes examples of behaviors that are associated with children, adolescents, and adults. For example, one criteria is often runs about or climbs in situations where it is not appropriate. This would be a behavior more typical in a child. So, in parentheses, they add a note which states that adolescents or adults may be limited to feeling restless. Aside from this consideration, a clinician must also rely on measures that are more telling of typical teen behaviors, such as the Connors-Wells Adolescent Self-Report Scale. However, if a clinician does not take the initiative to do a thorough assessment of history and relies on insufficient measures, the sensitivity of measurement may fail to show that an adolescent has ADHD. One important factor that may hinder proper assessment for teens is self and parent reporting. Developmental psychology theorizes that teens go through a stage of development where they seek to establish self-identity. This can be a difficult process for teens in general, and even more complicated for teens with ADHD. If teens in the process of self-discovery take on self-stigmatizing attitudes towards their mental illness, this could potentially derail and distort their self-identity. Research shows that adult and adolescent perceptions of mental illness is concerningly negative. A parent's perception of their ADHD teen has impactful consequences on teen lives into adulthood. A study on parent perception of ADHD behaviors highlights the influence of parent perception on actual measures of parent-child relationship quality. It demonstrated that positive outlooks of ADHD by parents resulted in less conflict between parents and their teens. Studies also show that parent informants are less reliable than teacher reporting. As we can see, informant reporting comes with its own set of problems and must be evaluated carefully by trained and experienced clinicians. Very much like teens, adults with late diagnosed ADHD come into their journeys of self-discovery with similar problems. The two main barriers for adults in being identified and being diagnosed has to do with their symptom manifestations and internalized ableism. How symptoms manifest for adults will be very different than symptom manifestations for children and adolescents. From a developmental standpoint, adults have way more behavioral expectations placed upon them and must adhere to rules of society as a survival mechanism. Therefore, adults with ADHD must have more control over their behaviors or risk being socially marginalized. This can result in adults adjusting and hiding behaviors and finding ways to cope with the effects of suppressing their natural behavioral instincts, leading to harmful outcomes such as depression, anxiety, and comorbidity of other mental disorders. It can also lead to internalized ableism, as adults with ADHD will oftentimes experience low self-efficacy as adults. They may erroneously attribute these negative feelings to their character rather than having a mental disorder. Studies show that late diagnosed adults experience significant impairment in their executive functions, which adults must heavily rely on in their daily lives. When we examine misconceptions of ADHD, we know that people who don't experience ADHD are less likely to understand what having ADHD looks like. These people include parents, family, friends, teachers, employers, and even physicians. Surprisingly, a study looking at the clinician assessment of adults for ADHD found that 23.9% of psychologists and physicians with at least a little experience with ADHD did not have any ADHD-specific training. This, coupled with the lack of consensus in the field of psychology on the diagnostic criteria for ADHD, could contribute to the overall problem. People with self-stigmatized attitudes or who are self-ableist contribute equally to the barriers of diagnosis because of their perceptions of ADHD. However, there are two groups of people within the ADHD community that are most vulnerable to the barriers to diagnosis, and they are individuals socialized as female and those who are in the inattentive subtype. Although many would argue that ADHD is overdiagnosed in the general population, the fact of the matter is that girls and women are statistically underdiagnosed. In a commentary article that talks about women's experiences in living with undiagnosed ADHD, they note that women struggle more with depression, anxiety, polypharmacy issues, and many comorbidities. Women who report ADHD symptoms are more likely to receive a diagnosis of depression or even borderline personality disorder instead of ADHD. Additionally, they point to the need for clinicians to improve their understanding of what ADHD looks like in women. For individuals who have been socialized as women, it is more likely that they have more successfully developed ways to hide their ADHD symptoms. It is because of this that the United Kingdom ADHD Partnership gathered their experts to come to a consensus on how best to identify ADHD in women. Their findings uncovered the need for more education for clinicians on ADHD identification and presentation, as well as on treatments for women who have ADHD. Another undiagnosed group are those in the inattentive subtypes, who coincidentally tend to be more often girls and women. Once again, female socialization is an underlying theme for them. However, within the subtype itself, it is evident that the nature of the symptoms are experienced internally and are not always externally obvious to others. This leads to symptoms often going unnoticed. So, if you are a child who is socialized as female and have the inattentive subtype, then you will be most likely to not receive a diagnosis for ADHD. In summary, ADHD is a neurodevelopmental disorder that changes over the lifespan for individuals who have ADHD. What signs and symptoms look like will depend on factors such as informant reporting, the attitudes people hold about ADHD, what stage of development a person is in, and the clinician competency in identifying ADHD in different age groups and genders. Early intervention for the identification is important for all people who have ADHD, because having ADHD in adulthood can have negative impacts on the quality of life and mental health. Girls and women who are in the inattentive subtype are the most underdiagnosed group and should be the focus of further research and education. The diagnostic process for youth versus adults is also subject to the developmental model, and therefore requires clinicians to be thorough and well-versed in ADHD identification in different age groups. Many studies suggest a reevaluation of the ADHD criteria in the DSM in order to make the detection of ADHD in adolescents and adults more sensitive. Clinicians should also be trained in their understanding of how ADHD shows up in girls and women, as this group continues to be underdiagnosed. It seems that the most problematic areas in the research on ADHD is identification and access to diagnosis. These themes have been recognized and understood well enough. However, in reviewing the literature surrounding these themes, it seems there would be a significant benefit to more research on girls and women of the inattentive subtype, so that we can identify even more ways in which ADHD is missed in this population. Future research should be focused on early intervention of ADHD for female children in the inattentive subtype, as they are the most vulnerable group. Equally as important is the need to further improve clinician competency in assessing ADHD. The implications of properly assessed, diagnosed, and treated ADHD can translate to a more accepting, educated, and supportive society at large, and could be applied on a global scale.